31st Dolan annual lecture. We want to welcome Dr. Wolf tonight. Thank you for coming. My job is to identify the bathrooms. And there will be a reception downstairs right after the lecture. We have one of our members recently died, and I'd like to have a moment of silence for Dr. Brink. Thank you.
Hi, I'm Lisa Kelly. I'm a pediatrician in the community and a member of the Dolan committee. And it gives me great pleasure this evening to introduce the 31st Dolan speaker, Dr. Andrew Wolf. Dr. Wolf is, and I will cheat because I know more about him as a person than just his CV. And of course, now I have my grocery list. Where to go? Where to go? But anyway, Dr. Wolf, so I'll do it when I planned it, right? Spontaneously. Dr. Wolf is a professor at the University of Virginia, and he is the director of the internal medicine primary care residency program. So he has a great deal of experience in working with patients and training doctors to really listen to and really understand where their patients are coming from. So he is uniquely qualified to talk about those conversations and how important they are. He also has been instrumental in writing the prostate, breast, and colon cancer guidelines with the National Cancer Institute. So very well informed in that regard. From my perspective, it's particularly fun to introduce Dr. Wolf this evening because Dr. Wolf is not only an expert in all of these arenas, but he's also my brother-in-law. And in our household, he refers to our daughter as the little whippersnapper. So he is alternately at our house either the big whippersnapper or Uncle Andy. So I welcome you, or ask you tonight to give a rousing welcome to my good buddy and brother-in-law, Dr. Andrew Wolf.
Lisa, thank you very much for that lovely introduction. And I really want to thank the Dolan family and the planning committee. This is a tremendous honor, and I hope I serve you well. We're going to be taking a deep dive into the nitty-gritty of prostate cancer and prostate cancer screening. So that means that those of you who had cocktails before this lecture should have had a double espresso. So my apologies in advance. Also, some early warnings. We are going to be talking about the prostate, so there is some bathroom talk. Sorry. Also, my brother is actually here in the audience, also a doctor, and he has graciously agreed to come up while I demonstrate some of the finer physical exam aspects of the prostate exam. But seriously, what I do hope is that at the end of this hour, you will gain a great appreciation for the importance of involving patients in many of the medical decisions that we make every day that we consider mundane in a way, like screening for prostate cancer. We're going to start with the story of Mr. S. Mr. S was actually a patient of mine. This isn't him. For patient confidentiality, I couldn't show a photograph, but this is a patient of mine who was a 58-year-old man with a history of high blood pressure, high cholesterol. He was coming in for a routine follow-up visit. The year was 1990. I was about 3 years out of my residency training. The blood test called the prostate-specific antigen, or PSA, had come into widespread use by this point. He was doing well. I ordered some routine labs, his cholesterol, some other routine chemistries, and I ordered a PSA on him. The PSA came back elevated. I sent him to a urologist. He had a prostate biopsy, and it diagnosed prostate cancer. He underwent surgery, what's called a radical prostatectomy, came back to see me 3 or 4 months later for follow-up. He'd been seeing the urologist. And when he came back, he explained to me that he was experiencing complete urinary incontinence. He had no control over his bladder. He was wearing diapers. He was age 58. And what he said to me has resonated in my mind ever since. He said, "Dr. Wolf, I wish you had never looked for that cancer." And that got me thinking. And what I started thinking about will form the basis of this presentation. So, by the end of this hour, I'm hoping that you will be able to discuss the benefits, risks, burdens, and uncertainties related to prostate cancer screening, that you'll understand the concepts of overdiagnosis and overtreatment as they relate to cancer screening, that you'll appreciate the importance of integrating patient values into the decision-making process related to cancer screening and other important decisions, and that you would be able to utilize decision aids as either as a provider or as a patient to facilitate cancer screening and other medical decisions that we often consider reasonably mundane or not. But what I really hope that you can come away with after this presentation is to answer these questions. What is shared decision making? Why does it matter? Why is it so hard? And how can we do it better? First, a little bit about prostate cancer. This is the prostate gland from a 1918 edition of Gray's Anatomy, not the TV show, the textbook. This is the edition, by the way, that my brother Steve used.
Still good.
So some statistics about the incidence of and mortality from prostate cancer. The red lines are the incidence or new diagnosis of prostate cancer in whites and black men. The black lines are mortality from prostate cancer, and this is over time. A couple of main findings from this graph. First, as you can see, black men are at significantly higher risk for developing and dying from prostate cancer than white men. You will also see a huge spike in the diagnosis of prostate cancer that started in the late 1980s and peaked around 1990 to 95. This was the advent of the PSA test. We weren't developing more prostate cancers in this country, we were just finding more of them. You'll also see that there was a steady decline in prostate cancer mortality starting in the mid-1990s and has been declining ever since. The proponents of prostate cancer screening would say this is because of the PSA. The opponents of prostate cancer screening said that this decline occurred too soon after the advent of the PSA to be ascribed to it. So the controversy started early and has been ongoing since then. Some other prostate cancer statistics. It's the #1 cancer diagnosed in men. It is the #2 cause of cancer death in men behind lung cancer. In women, it's breast cancer behind lung cancer. This year, there will be 165,000 new cases of prostate cancer diagnosed in the United States, and there will be 30,000 deaths from prostate cancer. The lifetime risk of being diagnosed with prostate cancer is 1 in 9, and the lifetime risk of dying from it is about 1 in 40. And 1 in 40 is a significant mortality burden. However, from those statistics, you can see that more men die with prostate cancer than from prostate cancer. So let's talk about the blood test. When this blood test came around, I can tell you that we thought it was the best thing in medicine since penicillin. A blood test that can detect cancer early. We didn't have anything like it before that, and we haven't had anything like it since then. So the appeal was great. It was the first blood test to come around for screening for cancer. Came into use in 1987, was widespread by 1990, so it spread rapidly. It's a glycoprotein, a chemical produced by regular prostate cells involved in semen production. It is produced and released into the bloodstream at increased levels from prostate cancer cells, hence its role in prostate cancer screening. And it definitely can find prostate cancer before it becomes symptomatic in many individuals. So from that standpoint, it's a very good test. But there are problems. There are problems with PSA screening. First, there's been great controversy about whether it in fact saves lives. There are significant number of false positives, meaning it's elevated, but you don't have prostate cancer. There are a large number, as you'll see, of false negatives. Normal prostate, a specific antigen level, but you actually are harboring prostate cancer. There's the concern for what's called overdiagnosis and overtreatment that we're going to be talking about. And there are the harms of evaluating an elevated PSA. with the biopsy, the prostate biopsy. About 3% of men have some complication, usually infection, sometimes bleeding, and up to 0.5% of men who are on Medicare will be hospitalized from complications of a prostate cancer, prostate biopsy, usually infection. And there are many harms from treating prostate cancer that is detected through the PSA test. We'll talk about each of these. This is a quote from Willett Whitmore, who was a urologist, chief of urology at Sloan Kettering for many years, and was a PSA skeptic. And I would like to present a balanced presentation, but I like his quotes. They're very pithy. And one of them was, "The current state of prostate cancer may not be good medicine, but it sure is good business. There are more people making a living from prostate cancer than there are dying from it." That's actually not true. There are about 10,000 urologists in this country, and there are 30,000 deaths from prostate cancer. So I would actually put this particular quote into the Rudy Giuliani, some truths are not actually truths. First of all, does the PSA save lives? That question, believe it or not, remained a question for 20 years after the advent of the PSA. We had no good clinical trials telling us whether PSA screening actually worked or not for 20 years. Then finally, the studies we were waiting for were published back-to-back in the New England Journal in 2009. A huge randomized trial from the United States and an even huger trial from Europe. So this is the study from the United States. 75,000 men were randomized, meaning half got PSA screening and half were sent to routine care with their doctors. They were screened regularly for 4 years, and then they were followed for another 9 or 10 years. This is the survival curve. And as you can see, there was absolutely no difference between the screening group and the control group in terms of lives saved from prostate cancer over about a 10-year period. So this was very disheartening. But there were a lot of problems with this study that were quickly identified. One, the control group. Half of the men in that group were getting screened for prostate cancer with the PSA. Because this is America, we were doing widespread PSA testing at that time, and they were getting routine care. So there was what we call contamination, when the control arm of a study gets the intervention. The other problem with this study is that all of the population involved in the study had been getting PSA screening prior to study entry, or at least many of them had been. So this population was enriched with a group of men who were at low risk for prostate cancer. So it would have been very hard to have seen a difference between the experimental arm in this study and the control arm. The other study that came out, same time, same day, was a European study, randomized 180,000 men in multiple European countries to PSA screening or no screening. In Europe, very few men get screened for prostate cancer. Or at the time, were getting screened for prostate cancer. So this was more of a pure experiment, where the men who got PSA screening got it, and the men who were randomized to not get it didn't get it. And as you can see here, there was a statistically significant difference that emerged at year 8 and got more significant over time by year 14 of follow-up, such that those who got screened had about a 27% lower chance of dying from prostate cancer than those who were not screened. The number of men needed to screen to save one life was about 781, meaning 780 men who got screened did not benefit in terms of having their lives saved over a 13 or 14-year period. Now, that sounds like a lot of men to be screened to save one life, but keep in mind that this is right in keeping with other screens we commonly do, like mammography in women in their 50s and 60s, or colorectal cancer screening. So these numbers aren't that bad. The number needed to diagnose with prostate cancer to save one life from prostate cancer was 27, meaning 26 men are diagnosed with prostate cancer over a 14-year period, but only one man will be saved in terms of his life being saved. So that's an issue called overdiagnosis, meaning diagnosing cancers that weren't destined to bother these men. We'll talk more about that in a moment. And as is true in many cancer screening trials, there was no impact on overall mortality, because it's hard to show an impact on overall mortality from one specific cancer. The only time we've ever done that is for lung cancer screening with CAT scans, because so many people die of lung cancer. It's a much more mortal cancer. This study came out last year, and I won't go through all the mechanics of it, but basically they manipulated statistics in a valid way to look at the differences between these two studies, and dealing with the issue of contamination in the control group in the American study, and actually found that there was about a 25 to 32% reduction in prostate cancer mortality in both studies combined by screening with the PSA compared with no screening. So it does actually look like prostate cancer specific antigen testing does help to save lives from prostate cancer. So if that's the case, what's the big deal? Why am I going to give the rest of this talk? Well, let's talk about the problems with prostate cancer specific antigen testing. False positives to start with. There are a lot of reasons why men have false alarms. Benign prostatic hypertrophy, that prostate grows with age. Many men, as you get older, have large prostates. In fact, some of the most meaningful conversations I've had with my brother Steve have been in public restrooms where we're standing there next to each other for 5 or 10 minutes waiting for things to get going. So as we get older, our prostates get larger, and that means that our PSAs rise. The problem is that the chance of having prostate cancer also rises as we get older. There is prostatic inflammation and infection, often asymptomatic, but that can cause a false positive PSA test. We find out when we do the biopsy, it was just some inflammation of the prostate, even though there were no symptoms. Fortunately, ejaculation has a transient and relatively modest effect on the PSA level, so I don't have to ask all my patients that delicate question. And then urinary catheters definitely cause a PSA elevation, so we don't test men who have Foley catheters in. The digital rectal exam has been thought to, and probably does, have a very mild effect on PSA, but probably not enough to cause normal PSAs to become abnormal. So it can be done in context with the screening exam. I'll explain why that may not be a great idea. Bicycle riding actually has been shown to elevate the PSA, but the study that showed that had men averaging between 40 and 150 kilometers of bicycle riding. That's a lot of bicycle riding. So the bottom line from this is, tell your patients not to ride their bikes to your office if it's more than 20 or 30 or 40 miles, and certainly not to ejaculate before they get on their bike. Now the takeaway, though, from this is that over 4 screens, there's about a 13% chance of a false positive, and actually, for a lifetime of screening, there's a very significant chance that a man is going to have a false positive elevation of their PSA. And why should we worry about that? Well, this is a concerning study. This was a survey of men who had had PSAs done. Some men had normal PSAs, and some men had an elevated PSA that it led to a biopsy that was normal. So in the green lines, this is men who had false positive PSA elevations by biopsy, so we know they were false positives. This was the group that had normal PSAs. They were surveyed 6 weeks after their PSA test or biopsy. Despite being told that their prostate is normal, 40% of men were still worried about prostate cancer. 36% of men perceived that they were still at high risk for prostate cancer, even though they had just been told that they had a normal prostate. And this is probably the most concerning statistic. About 30% of men who had just had a probe put into their rectum, a small harpoon stuck into their rectum and spearing their prostate gland, finding a normal prostate and told the whole thing was just a mistake, your prostate's normal, they feel life was better. That's the dodge the bullet phenomenon. You know, I was given a scare, I was told things were okay, I dodged a bullet, life is good. But the bullet, we were firing blanks with it. There was no bullet, it was a false positive. So that's a little concerning. This is the device we use. I don't use, I'm not a urologist. It's inserted into the rectum, and this little harpoon is speared into the prostate gland through the rectal wall. This doesn't look like dodging a bullet. This looks like a bullet to me. So then there's the problem of false negatives. I'm going to go through with you an inconvenient truth about the PSA test. So, conventionally, normal PSA, less than 4 nanograms per deciliter, we say your PSA is normal, no testing is necessary. PSA greater than 4, your PSA is elevated, you need a biopsy. But let's dig down a little deeper. This was a study done of men where they all had a PSA test and they all had a prostate biopsy. So even though their PSAs might have been normal, they still got the biopsy. And we can see some alarming numbers here. That about 25% of men with a PSA between 2.5 and 4 have prostate cancer. And a significant minority of them have a higher grade prostate cancer. So, doing the math, and I won't do it, I'll do it quickly. You take 1,000 men, about 7.6% of men have an elevated PSA, 25% have a positive test who have an elevated PSA, positive biopsy for cancer. About 19% of them have high-grade cancer, the ones that we worry about. About 92% of men will have a normal PSA, but 15% of them will have prostate cancer if biopsied, and 15% of them will have a high-grade prostate cancer. So doing the math, about 36 of that 10,000 men with a PSA greater than 4 have high-grade prostate cancer, and more men with a normal PSA have high-grade prostate cancer. So that's disconcerting, right? Are we missing the boat? Well, bottom line is there is no PSA level that accurately and consistently discriminates between cancer and non-cancer. So we somewhat arbitrarily pick a number of 4. Now don't freak out, men, because you can live with a higher grade prostate cancer and it can become detectable when you follow it over time. But what I would say is once it gets above 2.5, then you should be beginning to think about more careful screening. There have been a number of attempts, and I'm not going to go through these in any depth, to better discriminate between cancer and non-cancer when you have a borderline or high PSA level. The PSA velocity is simply the rate of rise over time of the PSA. So with cancer, the rate of rise tends to be higher than non-cancer. So following a PSA serially is a reasonable strategy. These are all blood tests that help to maybe discriminate between cancer and non-cancer, and they are somewhat helpful. The prostate MRI is an emerging technology that I think has great promise for helping us to discriminate between cancer and non-cancer, but is not yet covered by insurance. And then there's the digital rectal exam. What about that? The age-old finger wave. Unfortunately, as a screening test, we looked at this very carefully for the American Cancer Society guideline, and the evidence that it's an effective screening test for prostate cancer is actually terrible, especially in the hands of primary care doctors such as myself. And I consider myself pretty experienced, but it's just not a great test. It can be somewhat helpful in discriminating once you have a borderline or high level and maybe helping to make the decision about whether to pursue a biopsy, but it's really the least helpful. This says it may be more inconvenient, but the reverse prostate exam is a lot less embarrassing for the both of us. But I think the men in this audience might be somewhat relieved to hear that the digital rectal exam does not necessarily have to be a standard part of your annual physical. So let's talk a little bit about the issues of overdiagnosis and overtreatment. Willett Whitmore said this very succinctly: when cure is possible, is it necessary? And when cure is necessary, is it possible? And really what he's getting at is, are we finding the right men with prostate cancer testing? So overdiagnosis is the diagnosis of prostate cancers through screening that would not have been diagnosed during the man's lifetime if screening had not occurred. Never would have known it. Would have lived whatever their life was going to be. They had prostate cancer, but we never would have found it without the screening. The estimates of overdiagnosis range between 20 and 40% roughly. It's probably on the higher side of 40%. Overtreatment is basically treating these screen-detected cancers that never would have become clinically apparent during the man's lifetime. And that gets to the issue of overtreatment, which is a major issue. I'm going to talk about active surveillance and watchful waiting as reasonable strategies to cut down on the problem of overtreatment. So let's talk about what are the harms of prostate cancer treatment. I mean, if it were a benign procedure, why not overdiagnose and overtreat it and just get rid of the prostate cancers in this country? Well, this is why not. This was a study done fairly recently that looked at men 2 years to 15 years after they had had treatment for prostate cancer, localized prostate cancer, with either radical prostatectomy or radiation treatment. You can see that 10% of men had major urinary incontinence after screening. 80% of men had erectile dysfunction to the extent that they could not have sexual intercourse, and 60% of men with radiation therapy, had erectile dysfunction to the point that they could not have sexual intercourse. And over half of these men, not surprisingly, were bothered by this. A third of men who had radiation treatment were experiencing bowel urgency, meaning having to go move their bowels a lot, or at least feeling like they had to move their bowels a lot. So some significant morbidities from prostate cancer treatment. There is this emerging concept of active surveillance, which is a very appropriate way to cut down on the issue of overtreatment. The way it works is basically men with usually low grade, sometimes intermediate grade cancers are offered the option to monitor their cancer with regular PSA testing and regular prostate biopsies. And then treatment is initiated only if the cancer becomes more aggressive. This reduces the risk of overtreatment, and that's a good thing. But are we at the same time creating a large cohort of men who are anxious because they are now in cancer limbo? Again, think about it. If you had cancer and we're walking around with cancer and told we're not going to treat it, how would you feel about that? This was a study looking at just that, the issue of active monitoring or active surveillance. This was a British study, and in this study, they randomized men who had been diagnosed with low or intermediate grade cancers to either radiation treatment, radical prostatectomy, or active surveillance, active monitoring. And you can see that not surprisingly, the men who went to active surveillance ended up getting a lot less active treatment because they were just being watched, and over time, if their cancers progressed, they would get treatment. Whereas, of course, all these men got treated right up front. So this is a way to spare men whose cancers are low grade or intermediate grade from some of the ravages of the treatment itself. Does it work? Well, you can see up here, this is all three of the groups, okay? Look at their prostate cancer specific mortality over 10 years. Nobody died from prostate cancer in any of the groups. So it seems like it was a reasonable strategy to not treat these men. On the other hand, look at this. This is metastatic disease. And what you can see is, over 10 years, about 10% of men who'd been randomized just watching active surveillance ended up getting metastatic disease. So there's the drawback, except this was a British study. And in Britain, they included men who had intermediate grade prostate cancers in this group. And in America, we tend to treat men with intermediate grade prostate cancers right off the bat. So the generalizability of this study to the US is not perfect by any means. Also, they do a lot less prostate biopsies in their active surveillance in Great Britain compared to the United States, where we do biopsies more often. More painful, but we're probably more likely to catch progression. So not necessarily possible to generalize. Active surveillance is a good way to cut back on the issues of overdiagnosis and overtreatment. So how can we help our patients balance the benefits and harms that we've just gone through? Now that we're getting into the weeds, you can see that this is a fairly complex subject for just a blood test. These are some useful concepts for helping men strike the balance. And these are also helpful concepts in general when we're making informed and shared decisions. We're going to talk about informed and shared decision making. We're going to talk about the obstacles created by low health literacy and low health numeracy, ability to manipulate numbers and probabilities. We're going to talk about the benefit of using decision aids, and we're going to talk about something I find very useful called values matching scenarios. So informed versus shared decision making. Informed decision making includes helping men or anybody understand the benefits, risks, uncertainties of the intervention they're about to undergo. integrating the patient's values into the decision, and helping patients, choose a level of participation in the decision that they're comfortable with. Shared decision-making simply involves the healthcare provider getting involved with the patient to help them sort through all of this and integrate their values into the decision. And we take more or less of an active role depending on how the patient would like to proceed. In other words, their own role preference. Many patients will say, I don't know, doc, you decide. We'll talk about that. So thinking of this as a Venn diagram, doctors and healthcare providers in general make a ton of decisions without the patients. If you have strep throat, I'm going to be writing you a prescription for penicillin. You can refuse it for some weird reason, but we don't have much of a discussion of the pros and cons. I'm going to prescribe it. Patients, we make a lot of decisions without involving our doctor. I don't call my doctor when I'm going to take a Tylenol for the tension headache my brother Steve has created. And, so, and then we have informed decision making, which involves us providing information for the patients to make their decisions. And within that context, many decisions do benefit from our involvement. We're not just talking about prostate cancer screening here. We're talking about many, many decisions. Hormone replacement therapy for women going through menopause. That can be very challenging, and hormone replacement is highly effective for that. But it also causes heart attacks, strokes, blood clots, breast cancer, to name a few. Again, risks are low, but is it worth it to take those low risks to deal with hot flashes and vaginal dryness? These are important discussions. Treatment options for early stage breast cancer. I just had a patient refuse hormonal therapy, an older woman, for her early stage breast cancer because she was more worried about the osteoporotic hip fracture that she might experience from the hormonal treatment than she was about the risk of recurrence from her breast cancer. Statin therapy for high cholesterol in older patients. We don't have a lot of good data on whether it really helps if you don't have a heart condition or vascular disease. Cancer chemotherapy, when life extension is going to be measured in weeks and months. That may be critical. It might be just what you want to stay alive, to see your grandson born. Or you may not want to go through the ravages of chemotherapy. Cardiac catheterization versus medical management for stable angina, chest pain. Never been shown to help, never been shown to be superior to medical management to have a cardiac cath and a stent. But some people want to have a stent placed and know what their anatomy looks like in their coronary arteries, and some people just say, put me on a medicine to see how I do. Treatment options for early stage prostate cancer, yet another decision. We're talking about prostate cancer screening, but once you have prostate cancer, there are options with pros and cons. These are just a few of the many, many examples of medical decisions that involve or would benefit from shared decision making. There's great barriers to shared decision making. One of them is the problem of low numeracy. Here's some sobering statistics. About half of high school and college educated white women correctly estimated the likely number of heads on 1,000 coin flips. A third of respondents answered under 300 heads. Spoiler alert, it's about 500. Okay. That's concerning. Perhaps more concerning, under 50% of underserved Central Virginia men in a study I was involved with understood the terms erection and impotent. 5% of them understood the term incontinence. If we're talking about these issues, when men are deciding whether they want to get into all of this, we better use different terms depending on the patient population, like leaking urine or your penis getting hard enough to have sex. And make sure you see a flicker of recognition when you're talking about these things. So being explicit, unfortunately, is important, and it's not offensive to men or anybody you're talking about. One of my colleagues in OBGYN told me a story. This is a true story of a patient of hers. She asked her, "Are you sexually active?" And the patient said with a straight face, "No, I just lie there." That's a true story. So take nothing for granted. We have to make sure our patients know what we're talking about. So what can we do to promote truly informed and shared decision making? One thing we can do is to assign homework. There are a lot of patient decision aids out there. There are for prostate cancer screening. This is just a few of them. A lot of them are web-based. You can print them off and use them in your offices. I've developed a very simple one for our low literacy patients. I'm going to show you in a moment what I would consider the gold standard here, an interactive web-based tool. And these would be considered the core elements of an informed decision relating to prostate cancer. On the pro side, PSA screening does detect cancer at an earlier stage than if we didn't screen. It reduces the risk of dying from prostate cancer and from developing metastatic disease. But on the con side, some cancers detected by screening would never have become apparent over diagnosis. There are a lot of false negatives and false positives. We talked about that. A high PSA requires a biopsy, and biopsies are painful and can cause complications. The treatment, and this is a core one, the treatment often causes sexual, urinary, and bowel problems. And then there's the issue of active surveillance. Not all cancers need to be treated, but they do require periodic blood tests and biopsies. Are you ready to get into all of this with your PSA test? This is a pictogram from the U.S. Preventive Services Task Force. I actually disagree with some of their statistics, but it's one of the decision aids that's out there, and I just want to show you how it looks. You can't really see it project very well, but you've got a lot of little men up here. You've got 1,000 men screened. 240 will have a positive result over a lifetime of screening. About 100 will get a positive biopsy, will have prostate cancer. 20 to 50% of these men are overdiagnosed. Again, I don't buy all of these numbers, but you get the basic picture of this. 80 will choose active treatment, though they don't account for active surveillance. They mentioned it over here. 50 of those 80 will have erectile dysfunction, and 15 will have urinary incontinence. One man will be saved. Out of the 1,000, one man will be saved. It's actually better than that in a lifetime of screening. It's probably more like 2 to 3 men. But again, that's why I quibble with the U.S. Preventive Services Task Force. 3 men will avoid metastatic disease. It's probably higher than 3. And 5 men will die from prostate cancer, even though we tried to find it early and treat them and save their lives. This I consider the gold standard for informed decision-making and shared decision-making related to prostate cancer screening. And those of you affiliated with Georgetown can take some credit. Kate Taylor came up with this decision aid. She's a PhD at Georgetown University. And I consider this a wonderful tool. It's web-based, so your patients would need to have computer access. And it guides men through each step of the way with what goes on with prostate cancer screening all the way through treatment. And I'll show you what it looks like. Bear with me for a sec.
Welcome to the Prostate Cancer Screening Making the Best Choice website.
I am computer illiterate myself. There we are. Okay, so this is what it looks like. You can't really see very well on the side here, but it has sort of each step of the way with prostate cancer, early detection, active surveillance, treatment, the pros and cons of all of these things. And while you're going through this decision aid, at each step it has you pause and say, now how do you feel about prostate cancer screening? And at the end, it sort of has a compilation of what you, the patient, has come up with how you're feeling about it. And I'm just going to show you briefly one part of it that I find particularly useful. And this is basically what I'd call a values clarification scenario. Well, let's click here to get started. And
to help you get the most from this website, we need to get an understanding of your current opinions about prostate cancer.
So here you have to say how far along you are on this. I use this tool for men who've never been screened before. My feeling is once men have gone through all of this, they don't have to go through it every year or two. They've made their decision. So I'm going to check this box down here. I am unsure about prostate cancer screening. I've either never been screened or I've been screened very rarely. And then what we'll do,
this program is designed as an easy to use.
We're going to go down here now to is screening right for you?
This program is meant to help you make
And
the
we're
best
gonna show you-
decision for yourself about prostate cancer screening. As you've learned so far, whether to undergo screening is an individual choice. For Ron, screening gave him peace of mind. On the following screen, listen to Mark, who wonders if the PSA test really helped him.
So this will be two men with different perspectives.
I've always believed it's better to know more rather than less about my health. That's why I signed up for a free prostate screening program. It showed that my PSA level was higher than normal, so the doctor recommended a biopsy. Biopsy results showed that I didn't have cancer. I knew then that getting screened was the best decision for me. It gave me peace of mind to know that I do not have cancer.
So there's a man who was happy with his decision to be screened, and then here's a man who's not so happy.
Whether to undergo screening is an individual.
When I turned 50, I got my PSA checked because that's what the ads say, and my wife insisted. It came back high, and my doctor and I were afraid it was cancer. We rechecked it, and it was still high, so I got a biopsy. The biopsy said I didn't have cancer, which made me feel good at first, but my PSA kept going up. Now I'm 55. I've had 3 biopsies over the past 5 years, all normal. My PSA isn't going up anymore, and the doctor says this all happened just because my prostate is enlarged. But I still worry sometimes that I might have cancer. I often wonder whether this PSA test is helping me at all.
So there's the point counterpoint, and then they ask the man to gauge where they are based on this scenario alone. There's a lot more about the treatments, and I'm not going to do all that, but I'm going to show you what would happen.
Listen to the following statement about prostate cancer screening. Even though prostate cancer may never cause me any problems, I prefer to get screened so that I know whether I have prostate cancer.
So I'm going to disagree with that,
Does this statement sound like you?
and then we're going to go to the
Yes, no, or not sure yet.
we're going to go to the end now, and I'm going to show you what the decision worksheet would lead to.
Throughout this website, you have indicated how you feel. It appears that you are still unsure about prostate cancer.
Good. So what would happen is, as the man goes through and answers all the questions, they would be on this scale. So at the end of this decision tool, he would get the scale balancing either towards screening or away from screening. And this is a useful tool for men to do some pre-thinking before they come in to see their healthcare provider or between visits, so that they can come in and have a shared discussion about whether to proceed with screening. So in this man, I checked, no, I don't think I would want it after that one scenario. This is leaning away from screening. And again, this tool requires a computer. He does read it out loud, so you still have to have some literacy and numeracy, but more literacy to get through this. It's still a very useful tool so that this doesn't have to happen in the doctor's office where there's not enough time to do all this stuff. Let's see. Click out of here. I don't want to end this presentation.
Click on the bottom, PowerPoint.
Right here?
There you go. Yep.
No. Hold on a sec. Can I get... Sorry, guys. There we are. Great. Okay, so... Okay, thank you very much. Good. All right. I like using values matching scenarios. The decision to screen is a dichotomous one. Either you get screened or you don't get screened. So I think it's helpful for men to hear the perspective of somebody who would be screened and the perspective of somebody who wouldn't be screened. So I use this in the office a lot. I tell people you might want to be tested if you value finding cancer early, you're willing to be treated without a definite expectation of benefit, and you are willing to risk significant injury to urinary, sexual, and bowel function. You might not want to be screened if you place a higher value on avoiding the potential harms of screening, such as anxiety or injury to sexual, urinary, or bowel function. And again, this sometimes helps men align, like I'm more like the first one or I'm more like the second one. Unfortunately, shared decision-making isn't necessarily over once the decision to screen has been made for men whose PSAs are either in the borderline zone or are elevated. So I'm going to give you a couple of cases to show you the quandary that men still are in and have to face, and some useful decision tools to help that decision. We're going to start with a 65-year-old white man with well-controlled hypertension. He comes in for his annual checkup. He has no family history of prostate cancer. After learning of the potential benefits and risks, he chooses to be screened. His PSA is 1, and he did get a digital rectal exam, which shows a nodule. So he would generally be referred for biopsy. Now, there is an online risk calculator that takes this information and translates it into the risk for high-grade cancer. So you have a Caucasian man, age 65, PSA is 1, he has an abnormal digital rectal exam. He has a 2% chance of a high-grade cancer. These are the cancers we worry about. Case 2 is a 65-year-old black man with well-controlled hypertension. He's coming in for his annual check. He wants to be screened too. His PSA is a little higher, it's 2.5. His digital rectal exam is normal. He would normally be reassured that his test is normal, nothing to worry about. This is what his numbers look like, and you can see a significantly higher risk of high-grade prostate cancer. And why is that? He's African American, higher risk. His PSA is 2.5, which is significantly higher than 1. So putting those together puts him at higher risk. They also show in here the 3 men with thermometers who got infections from their prostate biopsy. So this can be a useful tool. What level of risk are you willing to tolerate? Is 2 in 100 too much? Is 10 in 100 too much? Are you going to go ahead and now somebody like this, we also might do some of those other blood tests I mentioned earlier. We also might monitor them more carefully to see if their rate of rise accelerates. So we might not just send everybody for biopsy who wants it, but certainly it tells you that following just the PSA level of 4, below 4 normal, above 4 biopsy is not a great way to do things. And this kind of a decision aid can be helpful. Case 3 is a 72-year-old man who's on dialysis and he has congestive heart failure. He remains very active, he's feeling well, and he's interested in prostate cancer screening. Actually, his wife, this is an actual patient, was interested in his getting prostate cancer screening. His life expectancy is well below, or was well below 10 years. You counsel him that finding and treating prostate cancer is more likely to harm him than actually benefit him. He wasn't screened, and this man actually did pass away within about 2 years of that office visit. So does informed and shared decision-making work? Well, it does work in the sense that it does improve men's knowledge about the pros and cons of screening, and more importantly, it lowers something called decisional conflict, meaning men are happier with the decision they make to screen or not screen. Whatever the decision is, they're happy and they can live with it better if they've gone through shared decision-making than if they haven't. I'm going to race through this issue because my eyes are beginning to glaze over, so your eyes must be beginning to glaze over. But I am going to talk a little bit about quality-adjusted life years. So what this basically is doing, though, is to combine the issues of how well do we live and how long do we live into one concept, the quality-adjusted life year. So it combines length and quality of life into a single unit. It does involve valuing health states on an interval scale between 0 and 1. 1 is perfect health, 0 is death. A lot of surveys are done for various diseases. Now we're talking about prostate cancer, but for prostate cancer, one might be asked to rate, how would you feel if we did prostate surgery, we felt we had cured it, but you were left with erectile dysfunction? I'd put that at about a 0.7 perhaps, or something like that. And then that is used to weight life expectancy in years. You multiply quality of life on that interval scale times length of life, and you get a quality-adjusted life year, or QALY. Now, I'm not going to go through these examples because we're all getting tired and we want to eat. But just to say, you can imagine, it's not hard to do this math, that if you live longer with treatment than without treatment, and if your quality of life is better with treatment than without treatment, your quality-adjusted life years are going to be positive. You're going to gain quality adjusted life years compared to not having treatment. But example number 2 can be living longer but not necessarily better. And this is the situation where your quality of life with treatment is worse than your quality of life with treatment because you experience things like erectile dysfunction and urinary incontinence or bowel urgency. But you live longer with treatment than without treatment. But there are scenarios where you can live longer but not necessarily better because of the quality of life hit, and you can lose quality adjusted life years. So you might live longer, but you don't live better. Willett Whitmore, that skeptic, said, the patient may not be dead, but he wishes he were. Quality adjusted life years have been used in prostate cancer screening. This was a study done of a theoretical cohort of 1,000 men who went through prostate cancer screening throughout their lifetime, age 50 to 70, I believe. And they did the quality adjusted life year analysis based on the range of quality of life that might be experienced by a man based on research, based on studies that have been done, surveys of men. And I'm not going to walk you through all of this, but I want you to focus on this bar here. So basically, if a man weights the quality of life hits from prostate cancer screening negatively, they will lose quality adjusted life years. But if they're willing to take the risks of all these things, the bowel urgency, et cetera, they stand to gain significant quality adjusted life years. Now you could say overall, you can see there's a net gain of life, quality adjusted life. So you could argue from a public health perspective we should just screen everybody. But there is the adage in medicine of primum non nocere, or first do no harm. And I think it's incumbent on us to inject shared decision making so we can try to avoid this end of the spectrum. So some take-home points. Many of the routine interventions in medical practice have significant potentials for both benefit and harms. Shared decision making is critical when that benefit-harm balance is too close to call and when the harms are heavily value dependent. If a man already has erectile dysfunction from surgery may not make much difference. Shared decision-making is not easy, but we have good tools to facilitate it, and we need to use them. I'm going to finish with the epilogue to the case of Mr. S. So I left my practice in inner city Boston in 1993, about 3 years after Mr. S went to surgery. I joined the faculty at the University of Virginia. This question of whether we're doing the right thing was rattling around in my mind. I got a $12,000 institutional research grant from the American Cancer Society. I hired a part-time research assistant, a guy I played soccer with at the time. He surveyed a bunch of men, and we gave them information about the pros and cons of prostate cancer screening after first surveying them about whether they'd be interested in getting a blood test that can find prostate cancer early. Not surprisingly, about 25% of the men, after learning the pros and cons of screening, preferred not to be screened for prostate cancer. The other 75%, after learning all this, still chose to be screened. Well, this study actually got a lot of attention, and it led to my being invited to join the American Cancer Society's Guideline Development Group. That culminated in my chairing the committee that wrote their guideline about 6 or 8 years ago that had as its centerpiece shared decision-making for prostate cancer screening. A couple of years after that, the American Urologic Association, which had had a pro-screening guideline, modified its guideline to have shared decision-making at the centerpiece of screening. This year, the United States Preventive Services Task Force, which is the major organization involved with screening in general, updated its guideline. It used to recommend against prostate cancer screening, and this year its guideline is to involve men in shared decision-making. So did I make the right call with Mr. S when I screened him for prostate cancer? Definitely not. I should have engaged him in shared decision-making, and I'm pretty confident he would have decided not to have gotten screened. But I do feel that Mr. S's suffering has not been in vain. Thank you very much. So at this point, I would like to open it up to questions and make this interactive after this brave effort of yours to keep your eyes open for the last hour.
Could you comment on transperineal biopsies versus rectal biopsy to avoid infection?
No, I think still the transrectal biopsy is preferred. So that technology, it hasn't made tremendous advances in the last 20 or 30 years. I don't sample, I'm a primary care doctor. Urologists sample more tissue than we used to, so the chances of detecting prostate cancer through the biopsy have gone up.
Dr. Wolf, thank you very much for a wonderful presentation and wonderful substance as well. I have two questions.
Sure.
Where does the velocity of escalation of the PSA come into play, and where does finasteride come into play?
Great questions. Everything I talk about will be controversial. So the PSA velocity is not great. The actual PSA level is a better predictor of prostate cancer than the velocity, but the velocity is somewhat helpful in terms of differentiating people who have very slow, indolent, probably either low-grade prostate cancer or more commonly BPH, prostatic hypertrophy. But it's not rocket science. We carry around some people use the 3/4 of a point per year as a cutoff, but it's not rocket science. And I do feel, however, that some of these other markers that I flashed up there quickly are going to have a lot more promise to help us differentiate who gets biopsied and who doesn't get biopsied. And I have to say, the MRI, the prostate MRI, it has been shown to cut down on the need for biopsy by about 20 or 25%. So we need to be actually doing more of them, but they're not covered yet by insurance. So that's not unusual for technology. There's a lag. Relating to the finasteride issue, for those of you who don't know what that is, it's a drug that blocks the effects of testosterone on the prostate gland, and the prostate gland is fed by testosterone, and prostate cancer is fed by testosterone. And so it is used in the treatment of benign prostate hypertrophy to slow the growth of the prostate and maybe even shrink it. And it actually has been found to prevent prostate cancer. There's controversy about that I won't get into. The effect of finasteride on the PSA is to lower it roughly by half. So it does make screening more challenging. The rule of thumb is to double whatever the level is that you have when you're on finasteride, but that's a rule of thumb and it's not science. It's not rocket science anyway. So it becomes iffy.
What's the role of genetic testing in helping to decide what type of treatment, whether to have treatment, whether to have radiation
Right.
after you've had a MRI and biopsy?
Sure, great question, which I don't have the answer to yet. But I will say this, that there are new recent genetic markers being identified for high-risk subsets of prostate cancer, not yet ready for prime time to screen every man with genetic markers to see who's going to get prostate cancer or who's not. But there are markers to identify certain subsets of prostate cancer that are particularly high risk. I will guarantee that in the next 5 to 10 years, they're going to be fairly commonplace and see those available to physicians to use to help figure that out. So we're not yet ready to say that genetic markers are useful for screening. There are genetic markers that can be useful for identifying appropriate treatment. They are currently being used for what's called castration-resistant metastatic prostate cancer to determine what the best therapy for those cancers are. I'm not an oncologist, and so this is getting out of my realm of expertise, but it's an exciting area, and also points to the fact that getting diagnosed with even metastatic prostate cancer is not a death sentence. We're getting better at treating that, and I have a patient in my practice we diagnosed with prostate cancer in 2000 through rectal bleeding, which is not a sign of prostate cancer. It had actually eroded through into his rectum. He had metastatic disease on presentation. He is still alive. That was 2000, 18 years later. Now, he's not doing well, but he did well for many of those years.
You stated that.
Aha, spoiled by the cell
On
phone.
the cases you presented, you keep mentioning hypertension. What is the correlation between hypertension and prostate cancer?
Oh, I was just trying to make them typical primary care patients. Everybody in my practice has hypertension and high cholesterol, until proven otherwise.
You stated that there was an overdiagnosis of prostate cancer between 20 to 40%. So for all general cancer screenings, would you recommend implementing like a test-retest method to minimize the likelihood of a false positive or false negative result?
So, in other words, following them over time rather than just jumping into a follow-up, like a biopsy?
Yes.
Yes. I would definitely, thank you for asking that. I would definitely recommend that. There is significant fluctuation. I've seen PSAs go from above 10 back down to normal. Again, because some of these issues like asymptomatic prostate inflammation and prostatitis that has no symptoms. So that's an issue. There's no urgency, and I ask my men to have patience, wait, retest, see where things are before we take the next step.
Dr. Wolf.
Good, thanks.
Dr. Wolf.
Yes.
Thank you for the lecture.
Sure.
What percentage of your patients actually go through the PSA testing after the shared decision making?
Right.
I've tried it with my practice. Ultimately, all of them get tested because they look at me like, you're not going to test me for cancer?
Yeah, no, that's interesting. I would say that actually my practice is probably following pretty much the study I did, that maybe not a full quarter, but a significant minority of patients choose not to do it. These are the people who say, they're the if it ain't broke, don't fix it people. I just want to come in for symptoms, pretty much, in general, in life. So even, treating their high blood pressure is hard and their cholesterol is hard because they don't have any symptoms. And so here I'm telling them about all these things they're about to get into. So I'd say maybe 20%, 25%, something like that. And hopefully, as we get better at differentiating cancer from non-cancer and get better at the morbidity of intervention, this will be less of an issue.
Well, the story of shared decision making, I just want to emphasize to the audience, may be good for prostate cancer, but not for everything else. Being a gynecologist in practice for many years, how many times I persuaded a woman, you have to have a mammography. And she said, no, I don't want to have x-ray, I don't want to have radiation, and here we got calcification, you got cancer, remove it, and she's cured. So I just want to emphasize that may be true about that because what you are saying.
Sure. Well, I will agree with you in part, and that'll be my next 1 hour talk. Will be about shared decision making for mammography in young women, because you had the risk of breast cancer goes up quite exponentially as we get older, as women get older. The age between 40 and 44, there is still a benefit to screening. There is still a benefit, but you have to screen almost 2,000 women to save one life. Many women would say, well, I could be that one, right? And they would be screened. Some women would say, well, I don't want to, blah, 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 I don't want the radiation, etc. But I would not disagree with you when it comes to age 45 or older. It's just the risks and the benefits tilt towards, that's not one that I do share decision making. But women will tell me, I don't want to go through it.
Now we have to be a good physician.
That's right. I mean, well, our responsibility is to know when we should be doing shared decision making. Another example, since we're in cancer screening, is in cervical cancer screening. There is no question. Do you want to be screened for cervical cancer with a pap smear or HPV test? No. It's like it's time for you to be screened. Anybody can refuse to be screened or refuse any intervention, but there's a right to refuse, but that's different from shared decision making. That's because the benefits of screening for cervical cancer far outweigh the risks.
Dr. Wolf, how concerned you are if you get a pathology report of the dysplasia changes in the prostate cells?
Yeah. Well, then we're getting really into the weeds of prostatic intraepithelial neoplasia. I personally, I'm not that concerned. But depending on other factors like their PSA level and are we missing something, I may get a urologist involved in that. But by and large, cancer, I think we have to do a better job helping men understand that you can live well without treating a prostate cancer and without treating this condition of prostate intraepithelial neoplasia.
Thank you for your talk. It's really informative. This is a general question. Do you know the writings and the ideas of Dr. Norton M. Hadler from North Carolina, Chapel Hill? He writes in general about the state of medicine and the practice.
Gotcha. No, I don't.
They overuse and they overtreat. And his books go on to talk about prostatic cancer, hypertrophy, and hormonal issues, rheumatology issues, etc., and his ideas that he expressed way in the early 90s.
Mm-hmm.
I guess that coinciding with the PSA fever is very much in line with what you today in 2018 are talking about.
Right, though I don't know his work, so I don't know. I mean, there have been a lot of PSA nihilists out there who feel that we are creating an industry, as sort of the medical industrial complex, like that Willett Whitmore test kind of quote about, more men or more people are making money from prostate cancer than they're dying from. I'm not one of those people. Nor am I a pro-screening person. I'm a pro-choice person when it comes to prostate cancer screening. Not to get political.
Dr. Wolf, you'd be applauded for your role in bringing shared decision-making and to get all three major organizations, the ACS, Preventive Services Task Force, and urologists all on the same page for shared decision-making is fabulous.
I'm not taking personal responsibility for that.
My question is this, though. What has been the uptake and acceptance of this? Is there any data on how well the internists and urologists are doing on this?
That's a great question. And no, I can say definitively, we're doing terribly at it. We're doing terribly at shared decision making. And that's why I'm giving these talks, to try to get this more disseminated. I mean, every organization now recommends it, yet when you survey men, most men don't recall having been involved in the decision to be screened for prostate cancer. And that's still the case. I haven't seen any data from this year or last year. And I do have to say the U.S. Preventive Services Task Force is a very influential organization. I was actually very dismayed when they came out against prostate cancer screening a number of years ago. And because I'm not against it. I think most men choose to be screened. And what happened after they came out against it was you saw it, the incidence of prostate cancer started dropping quite significantly after their recommendation to not screen. So a lot of physicians stopped screening. It didn't involve men in that decision, they just stopped screening. It's beginning to plateau, they tend to be more conservative, follow only randomized trial evidence. They didn't really pick apart some of the flaws of the American trial as much as they should have, and they've changed their thinking. And the reason that the U.S. Preventive Services Task Force changed their thinking had nothing to do with me. I'll just say that right out. It had to do with they gave more credence to active surveillance, because active surveillance has taken off in Europe and is beginning to take off in this country. And they feel that has mitigated the harms of prostate cancer screening enough to tilt the balance towards too close to call, we're going to call for shared decision making.
Dr. Wolf, I guess I might be the last question. I'm an internist who trained at Georgetown, but I practice both in Washington and in Trinidad and Tobago. So in your experience, have you seen different genetic subsets of patients coming from different social and different ethnic groups? Because I currently have a patient, he's actually a Caribbean man that I see in Washington, with PSAs of 30 to 40, with repeatedly negative biopsies, and he's completely asymptomatic.
Ah, very interesting.
Yes.
Very interesting.
And,
No, to answer your question, no, I'm not aware of that.
Yes,
So,
and you know, in the Caribbean, of course, we have a lot of challenges because access to care is definitely a big problem.
sure.
But you know, I've been practicing shared decision making for the last 20-something years. It takes time to practice shared decision making, but the changing guidelines, of course, makes it very difficult.
Yes.
You know,
Yes.
one group is saying one thing, and the USPTSD
Yes.
is saying something else.
Yes, it certainly
So,
does.
But you've not come across different ethnic groups that
Not
are
with
very
that
elevated?
specific issue of highly elevated PSAs, but no evidence of an explanation for that,
Yes.
suggesting that there's something about the PSA generation itself that is different. And so I have not. And you are, I appreciate what you just said also about the time issue. I'm a very busy primary care doctor myself, and that's why I feel strongly that we need to move this out of the office visit and do it pre-visit or post-visit, and so that patients can come in forewarned and forearmed to have this discussion more efficiently and more effectively than just you and I trying to get through all this crap, not crap, important stuff, but in the context of a 15-minute visit. Almost impossible.
And thank you very much for a
Thank you.
wonderful presentation.
There you go. We have an honored tradition here of presenting this plaque to you. It was a picture of my father drawn by the first chairman, who was a doctor in this area. And we've, over these years, we've sort of had these handed, and hopefully these are across the country. But I hope you enjoy it.
Thank you so much. I'm very honored. Thank you.